Hello, everyone. This is Siddharth Dambar, physician here at Chicago Arthritis and Regenerative Medicine. We're going to get started with our webinar today. As we get started, so today we're talking about regenerative medicine treatments for arthritis, tendinitis, injuries, and back pain. If you have any questions as we're talking, please enter them into chat or into the question section, and I will try to answer them as we're going along. I'll pause here and there. I'll be talking for about 30 minutes, and this always works better if there's plenty of questions and I can answer your direct issues while we're here live. So what you will get from this webinar, you'll learn about the best available treatments for arthritis and tendinitis that do not require surgery, include utilizing your own blood platelets, your own bone marrow stem cells, what is legitimate and not legitimate in the field of regenerative medicine, how to choose the best physicians and clinics for regenerative medicine as well. And after we're done, just if you have any questions, you can always email us. You can always call us. We're always available for any questions. You can always go to the website, chicagoarthritis.com. And I see someone just mentioned that they had to leave a little bit early. Yeah, so you'll actually get an email with a chance to rewatch this after we're done today. Okay, great. So the big question is, what would you do if your pain was controlled? How would your life improve? What exercises would you restart? And what activities with family and friends would you participate in again? So a little bit about who I am. My name is Siddharth Dambar, physician here at Chicago Arthritis and Regenerative Medicine. Specialist in rheumatology, specialist in regenerative medicine, specialist in image-guided musculoskeletal injections, in practice since 2008. Involved in regenerative medicine since 2008 and within the Regenix network since 2012. The Regenix network is the largest group of physicians who are collaborating, sharing best practices, sharing what seems to work for our patients, and utilizing similar protocols and collecting data as well to really give our patients the best chance for good outcomes. So my personal journey into regenerative medicine. So I used to play a lot of tennis when I was younger in high school and never really had pain to my shoulder. As I got older, and in my medical training, I started to learn about musculoskeletal ultrasound. And one of the things I noticed was that in my own shoulder, even though I didn't have pain, I had some chronic changes in the rotator cuff tendons, as well as in some of the ligaments. And it made me realize that there was a lot when it came to tendon and ligament injuries that probably were not being optimally treated based on kind of standard medical practice. And I wanted to learn more. And so in learning more about these kind of treatments, I started to learn about platelet-rich plasma. This was back in 2007, 2008, very early stage. I ended up connecting with other physicians who are very much at the cutting edge of things, and progressively just sort of got more and more involved in this, introducing platelet-rich plasma to my own patients, then eventually even introducing bone marrow stem cells. So there's, traditional care for tendinitis, sprains, strains, arthritis, joint pains, back pain. It's very flawed. It's really all about masking the pain and then waiting for eventual surgery. That's really terrible. The equivalent of that would be if you had diabetes, and instead of trying to treat it with either medication, diet, exercise, supplements, whatever, that you just sort of waited to get your first heart attack or your first stroke. Nobody would recommend that these days, but that's sort of how we handle musculoskeletal issues, which is utilizing pain medications that don't fix the problem, that have a lot of side effects. Traditional injections like steroid injections, radiofrequency ablation, nerve blocks, they give pain relief short term, but they have a lot of side effects as well. They're not really healthy for tissue. Surgery, on the other hand, and just waiting for surgery, surgery is appropriate in some cases, but it's not appropriate in the vast majority of people who are presenting with pain. And the problem with surgery is that it's higher risk in terms of bleeding, infection, tissue damage, a lot of other issues. Also, if you're there's certain routine surgeries like arthroscopy, if you were to get knee arthritis, or it'll actually accelerate the arthritis process because cutting out tissue leads to more instability. And so for those of us that are involved in regenerative medicine, there's a strong sense that 80% of what is currently being handled by surgery will eventually be handled by regenerative medicine, if not already, but will be over time. And that would be in a similar way that in the past, all like significant cardiac issues were handled with cardiac surgery. And now the vast majority is handled with percutaneous needle-guided procedures without open surgery, medication, diet. Like it's just handled, so much is handled without actually having to go to big open surgeries. And the sense is that's how musculoskeletal medicine will proceed as well. So in searching for better options, my own career, the treatments for patients have to be low risk, avoid serious side effects. They should address the source of the problem, including instability. That's a big one. And then also inflammation or metabolic issues. It should improve the actual cause of the problem. And it should give you a more longer-term treatment, a more longer-term improvement. So imagine reducing your pain and getting back to the activities you care about without surgery or pain medications. So regenerative medicine, it's the process of utilizing your own body cells to treat arthritis, tendinitis, injuries, and back pain. And really, we're just 100% focused on musculoskeletal issues. If you've got other medical issues that you're inquiring about, whether it's chronic spinal cord injuries, chronic kidney disease, lung issues, this is not the forum for that. And frankly, there's very little data for those kind of things. So in the normal healing process, take something as small as, let's say, a cut on your finger. You have platelets that first infiltrate the area. It stops the bleeding. The platelets then release growth factors. Those growth factors then stimulate your local stem cells, which then starts a normal process of healing after an injury. And that includes bringing in other cells and growth factors into the area, and then through inflammation and more cells, eventually leading to a slow and cellular repair process. This works well for tissue that has good blood supply. That would include the skin as well as muscles, but tissues with poor blood flow do not heal in that same manner as well, because they just don't have the same kind of blood flow to promote that. So that includes tendons, cartilage, ligaments, discs, labrum, and menisci. And the thing is, those tissues are very hardy, but if they've been recurrently injured over time or more severely injured from an injury, then they tend not to heal very well on their own. The body will tend to scar it down, try to just stabilize it as much as possible. But in general, what happens is that people then develop chronic instability in the area, and then eventually more and more pain and inflammation. Regenerative medicine is the process of taking those same cells that are involved in healing. That includes your own platelets as well as bone marrow stem cells. And then under high-level imaging guidance, injecting that into the tissue that's been damaged. Start that normal healing process or try to at least optimize what the tissue can be. So there's a number of reasons why regenerative medicine makes a lot of sense. To begin with, we're trying to treat the source of the problem. So the source of your problem, it's not an X-ray in your doctor's office. The source of the problem is that you've got chronic instability and you've also got chronic inflammation. And we can treat both of those with regenerative medicine. These treatments are needle-based. They are safer than surgery. They are effective for most musculoskeletal conditions, not everything, but for most. And again, for those of us that are working in this field, strong sense that eventually majority of what is handled through open surgeries will be handled through regenerative medicine. So how does regenerative medicine work? So as I mentioned, we can optimize damaged cellular health of tissue. We can also improve the strength of the supporting soft tissue structures. That includes ligaments, tendons, so that you have an overall stronger unit. We can reduce chronic inflammation, and we can even improve the neuromuscular health, meaning nerves that have been injured around the joint or the tendon as well. So what makes regenerative medicine expert? This is a very, very busy slide, but I think for folks who are trying to maximize, their treatment options, this is stuff you should understand. Certainly, this is stuff that your physician should understand. So What makes regenerative medicine expert is the following. Number one, they should be a musculoskeletal expert. That means is that your doctor should not be treating high blood pressure in one room, low testosterone in another room, somebody's erectile dysfunction in the next room, and then jumping in and trying to treat your knee or your back. You should really be focused on just, what they're meant to be doing there. And that's being a musculoskeletal expert. Number two, they should be a non-surgical musculoskeletal expert. So our surgical colleagues, orthopedic surgeons, they're trained very well in how to do surgery. But there's aspects of non-surgical treatment of musculoskeletal issues that they're not really trained in. And that includes utilizing high-level image guidance like ultrasound and X-ray to properly do these injections. That's important because image guidance should be used for all procedures. And the reason why is the cells that we're injecting, we're trying to inject it into very specific damaged tissue. And if you're off by even a millimeter, those cells are not getting to the right tissue. And if that happens, you're not going to get the right kind of response. Then the other part of this is that I do see physicians who will utilize a lot of traditional treatments like steroid injections, as well as nerve blocks, sort of left and right in patients. And they don't really get how inflammation can be utilized in a productive way. And that's how regenerative medicine works, through inflammation. And the problem is that if you're getting all these other types of treatments and injections that are not healthy for the body, eventually it'll limit your body's ability to actually properly heal on itself. And then the next is understanding the different types of biologic treatments that are used. So important, because if your physician sees that every patient that comes in needs the same treatment, they're not giving you a personalized or bespoke treatment process, but just a generic treatment, they're not going to treat you correctly. So as an example, a lot of the medical literature for PRP has very poor quality studies done, in large part because they're using a very low concentration of platelet-rich plasma. And only recently have some major orthopedic surgery organizations realized that that's not really the right way to treat this. You should be using a higher dose of platelets. Well, that's a pretty key understanding when it comes to how to use these kind of orthobiologic treatments, understanding what makes a good product and when to use one versus another. Because in the end, you need to have a personalized treatment approach. It shouldn't be every patient gets the same thing, yet that they're a hammer and you're a nail, and that everything is the same thing again and again. There has to be a personalized approach to this. Next, they need to understand how prolotherapy works. Prolotherapy is so key in this. It's about treating the ligaments, to treat instability. I'll talk about that a little bit more in a moment. But not doing that really it's kind of short thrifts your ability to get a good result here. And then they should be transparent about results, about reasonable results and candidacy for treatment. I see all over the spectrum. I see some healthcare practitioners that give pie in the sky expectations, which is not appropriate. And then I see other physicians who don't understand the data or what's possible, and then tell patients they don't know if it'll help. Well, that's probably not an expert in this kind of treatment then. And then they should follow your results long-term. This should not be something where you see a physician once and you never see them again, that they're not involved in your care. That's not really appropriate. These treatments, you'll do better if you maintain connection with your physician long-term. And they should guide you through the process. These treatments are newer. They're not new. They've been around for 20 plus years now, but they're newer. And so guiding you through the process is key, because people always have questions and they need to understand how this works. It's different than how other treatments work. So some really common questions that I hear: is this legal? Absolutely. There are very strict guidelines from the FDA. And as long as you're following those guidelines, it's legal. You have to be treating musculoskeletal tissue, not other types of tissue. You need to be prepping cells and re-injecting them the same day. You cannot be saving them and using them later on. And then lastly, you need to be using your own cells, not somebody else's. If you're following those three rules, you are most likely on the right side of the law, and you're probably doing something legitimate based on FDA and FTC guidance. If I'm older, shouldn't I use someone else's cells? No, right? That's a common thing that you'll hear from some people, but there's no evidence of that, right? And so for most orthopedic conditions, there's good evidence that using your own living cells is effective. Use your own cells. Is there an age limit? So for almost everything that we treat, no. The one exception are hips. That can be worse if you have bad hip arthritis. The outcomes can be worse if you're over the age of 65, but for everything else that we treat, age does not make any difference in terms of improvement in pain and function. Other questions. So what sort of doctor does these treatments? Again, as I mentioned, a physician who's focused on musculoskeletal conditions, physician who's focused on non-surgical treatment of your orthopedic issues. And again, all those things that I mentioned that makes a regenerative medicine expert. So can these treatments help if I've already had surgery? Depending on the type of surgery, yes, if you're talking about like arthroscopy. If you're talking about like you've had the joint replaced, less so, right? It's less so. Now that you've got hardware there, you're kind of outside the realm of what we can do for you from a non-surgical standpoint. We can treat the soft tissue structures around the joint if it's been replaced, but my general rules for orthopedic surgery is try to keep your anatomy, avoid surgeries that just cut out tissue and don't really fix anything. Always consider regenerative medicine treatment option if you have been recommended surgery as well. So we're going to talk about really 3 key regenerative medicine concepts: prolotherapy, orthobiologics, and interventional orthopedics. So there's this concept in architecture called tensegrity. What that means is that when you take individual units that are weak on their own, if you put them in close approximation and then compress them together, that overall unit is much stronger than the individual pieces. So the same concept applies in medicine, and that's called biotensegrity. So prolotherapy is the process of injecting your own cells into those soft tissue supportive structures that surround the joint to strengthen it and stabilize it. The key is that you want to treat all the different layers that are involved, and you want to treat above and below where it's involved as well. So you need to be very comprehensive. What happens is you get a progressive strengthening over time, progressive improvement in function, progressive improvement in pain as well. And those results tend to be more durable and longer lasting if you take that approach. That's in comparison to if you only treat the joint and you don't treat all the surrounding soft tissue structures, in which case people's improvement will be more limited. So this is a case study of a 71-year-old man who's had 2 surgeries in the past for his lower back, laminectomy, and still having back pain. Very common. You see that in back surgery patients where it's great for treating nerve entrapment or nerve compression symptoms, but not so great for treating the back pain. And so in this case, we end up first using his own platelets, platelet-rich plasma, as well as platelet lysate to treat the ligaments, facet joints, muscles, and epidural space. With one treatment, he had about a 30% improvement. We ended up escalating to utilizing his own bone marrow stem cells, treating those same structures. He's now dramatically better, 75% improved, and continuing to do well. Keys here are we treated all the relevant structures, not just the epidural space, but everything else surrounding it. And just seeing how using a stronger cell type bone marrow, in his case, ended up working better than just platelets. Orthobiologics, these are the biologic cells and tissues that we inject into damaged orthopedic tissue. As I mentioned, utilizing your own normal healing cascade, and please use your own cells, not somebody else's. The data on using somebody else's cells is limited. The data for using your own cells there's a ton of data on that. There are some potential risks in using someone else's cells. Your body will recognize it as foreign, and that can be an issue. So platelets are really the first line orthobiologic. Again, platelets are involved in initial acute injuries and helping to start the healing process by stimulating your own stem cells using focal inflammation, and again, stimulating your own local stem cells. So there's different types of platelet preps. There's platelet-rich plasma. That's where we take a sample of your blood, concentrate into a high concentration of platelets, and then re-inject that same day. What that does, is stimulate your own stem cells, start the healing process. Platelet-rich plasma in that form is very good for joints and tendons. Platelet lysate is what essentially we take that same platelet-rich plasma and now we filter it, crack open the cells, and just take the growth factors. That tends to be a little bit less inflammatory, better for nerves, better for ligaments. So as I mentioned, when you prepare this, you have to centrifuge this down and isolate the cells that you want. So higher concentration of platelets, not a low concentration, is better for joints and tendons. If your physician is telling you you're going to get 3 to 5 weekly platelet-rich plasma treatments, it's likely they're using a very low concentration of platelet-rich plasma. We know that because if you're using a high concentration, you'll have more inflammation for the first week, and you probably wouldn't come in for a second treatment right off the bat. And the right way to do this is to use a higher concentration of platelets and then let your body naturally heal and recover for the next few months after treatment. So the picture on the right, two different types of platelet preps. There's the amber or yellow colored one. That's a high concentration of your own platelets without red blood cells, not as inflammatory, very good for joints and tendons. Then there's a platelet-rich plasma on the right that still has a lot of red blood cells. I would not recommend injecting that into the joint or tendons, too inflammatory. Can still be helpful for muscle injuries, however. So again, having that kind of dexterity and understanding of when to use what is important. This is a case study of knee tendinitis. This is a gentleman who was referred to me by his sports medicine doctor. He had persistent pain despite cutting back his activity. He's a cyclist. He had an MRI that showed patellar tendinitis. The picture on the right is an ultrasound. That's the kneecap, the white structure there. That is the tendon. As you get closer to the kneecap, you start seeing some changes in the tendon that is consistent with patellar tendinitis. So in his case, he ended up having platelet-rich plasma treatment. We did it twice. We did this under ultrasound guidance. That's how you make sure you're hitting the right tissue. And after 2 treatments, he was able to get back to cycling, his full activity, doing great. Picture on the right, this is an ultrasound picture. Again, kneecap, tendon. It's a very zoomed up view of the needle, and that's injecting directly into where the tissue is pathologic. Important to inject it exactly where it's problematic, because that's how you get the best kind of result. I ended up seeing him 3 years later. Now his other leg was having problems. He had a hamstring issue. Again, treating with his own platelets, platelet-rich plasma, and he's doing great. What I like about this kind of case is, number one, treating some soft tissue issues with platelet-rich plasma, meaning the tendons. Number two is how repeat treatment is sometimes necessary and can be more beneficial. And number three, how using that treatment for another injury later on is a great use of this kind of treatment as well. Next type of orthobiology to be aware of are your own stem cells. It is the main cell that drives tissue repair and recovery after an injury. Use your own cells. Very little data on using someone else's cells, theoretical risk as well. Use your own cells. Bone marrow-derived stem cells are what's legal in the US. No other type of stem cell product is legal. Fat stem cells are used, but understand that the way that it's processed, it is not a pure stem cell product. To get a pure stem cell product from adipose, you have to use an enzyme called collagenase. The FDA has concerns about utilizing that in humans. So not allowed in this country, it is allowed in other countries. You can still use fat or adipose, but you're generally using it for structural support. Let's say for injecting a rotator cuff tear, you may use your own platelets or bone marrow stem cells, and then add in some adipose just to help with some connective tissue support. You may have heard, probably not as much nowadays, but amniotic or umbilical cord cells. There's no living cells in these products. That's why they've been, it's the only way to give these safely is if you have them processed. But people were falsely and incorrectly marketing that as a stem cell treatment without any actual living stem cells in it. And so the FTC and the FDA have really clamped down on clinics that are doing that. And so you probably don't hear too much about amniotic and umbilical cord cells these days. But in the past, it was much more in social media and all over the internet. IV stem cells, you hear that in other countries. You never hear that in America. It's illegal. Again, no proven benefit for orthopedic conditions. I would be very cautious about doing that. It just doesn't really make sense. If you're treating an orthopedic issue, like a knee problem, you need to be treating the knee. An IV is not going to get those cells to the knee. When it comes to stem cell treatment outcomes, yes, we can improve your pain and function even if you have advanced arthritis. Can we improve how your images look? X-ray and MRI. If you've got advanced arthritis, I can't make your X-ray look like what it was 10 years ago. If you've got a tendon tear, in some cases we can. If you've got a tendon tear that's less than 2 centimeters, same thing with a ligament tear, yes, we can do that. I'll show some examples. If you've got swelling in the joint, progressively over time, that'll go away with treatment due to reducing inflammation. And if you've got a condition called avascular necrosis, where there's damage in the bone because of lack of blood flow, we can improve that in early to moderate conditions. Later conditions generally need surgery. Can we treat bone-on-bone arthritis? You know, this term bone-on-bone arthritis, such a overused term by physicians. it gives the impression, when you look at an x-ray and you tell somebody about bone-on-bone arthritis, it gives the impression that all is hopeless. And the thing is, we know it's not truly bone-on-bone, because even if someone has advanced arthritis, they still can bend the knee. It might not be fully, but they can still bend the knee. Range of motion is important. And if you can still push your joint through a good degree of range of motion, you likely could still benefit from one of these kind of treatments. So yes, regenerative medicine treatments can still help if you have bone-on-bone arthritis. Understand that arthritis is a biologic condition. It's not just an x-ray up on the wall that your physician is showing. It's a biologic condition. There's living tissue there. And it's about instability, it's about inflammation. Those are things that can be improved. And so if your range of motion and function are still good, then good outcomes are still very possible. Caveat to this, advanced hip osteoarthritis is very challenging to treat. I'll generally refer patients to surgery for that. And the expectations, if you've got advanced arthritis in other joints, is that yes, we can improve your pain and function, just cannot reverse necessarily what your imaging looks like to what it was 10 years ago or when you were 18 years old. Yep, I see the questions. I'll get to that in a moment. So a couple of case studies. This is a question, can we treat tendon and ligament tears? So this is a case study of a 20-year-old man with an ACL tear. We can definitely treat partial thickness tears. In some cases, we can treat full thickness tears, and I'll show what I mean by that. He had an ACL tear a few years ago. I treated him with his own bone marrow stem cells. A couple months later, by 3 months, no pain, restarting dynamic activity, and his imaging looks amazing, which I'll show in a moment. So the picture on the right is an X-ray image. Again, that's the kneecap and patella. It's the femur, the thigh bone. This is the shin bone, the tibia. This is a needle under high-level X-ray guidance. We are injecting into the ACL at every level. And what you see is that it's lit up. And what you see is that as we inject cells back in there, we're hitting every level of the ACL. So these are his MRIs before and after his treatment. So what's exciting about this is his not only his clinical improvement, but his MRI improvement. MRI on the left is his pre-treatment MRI. Again, kneecap, this is before treatment. Thigh bone, shin bone, that's the ACL down there. As you follow this up, what you see is that it starts to get very hazy, very wavy, and you no longer have a good view of it. So this has been read by the radiologist as likely a full thickness tear. Now, this is 3 months later after treatment, another MRI. There's his ACL now. Now you see a nice, clean, linear structure, just very nice looking. Consistent with what appears to now be a healed and normal ACL. And that's how the radiologist has read this as well. Exciting because we've not only treated his pain and his functional limitations, but we've actually also improved what his MRI imaging looks like. This is a man who is a 57-year-old man. He's a general contractor. He does a lot of overhead work for decades. So he came to me with right shoulder pain, and his ultrasound showed the following. So he ended up getting his own bone marrow stem cells and PRP injected. So the picture's on the left. That's the bone. It's the bone. That is rotator cuff tissue. And this big black hole right here, that is a tear in the rotator cuff. That is a full thickness tear, all right? And so this is his ultrasound 3 months later. Again, that's a rotator cuff. Where you previously saw the hole, you now have filled in tissue. He's doing great from a functional standpoint, from a work standpoint, and excitingly, he's doing great from a imaging standpoint as well. Interventional orthopedics is the concept of using image guides to treat orthopedic injuries. So I have colleagues who feel that just by palpating the skin, they can precisely inject the joint. Perhaps they can sometimes, but the data shows that, in studies shows that people who do injections blindly, definitely not 100%, even injections into knee joints that are considered easier injections, probably about a 70% hit rate if you're doing it blindly. If you're injecting steroids, it's one thing. If you're injecting your own cells, if you're injecting your own cells, you have to be down to the millimeter specific. And here's why. So ultrasound on the left, that's the bone of the shoulder. That is the rotator cuff. This tiny little hole right here is his tear, and that's the needle injecting into that tear. So that tear is very small. Like this is, again, a zoomed up picture. That tear is about 1 millimeter by 1 millimeter. If we're off by even a millimeter, we're not injecting into the tissue that needs to be treated, and you're not going to get the right kind of response. Picture on the right, this is the ball and socket joint of the shoulder. That's the needle. It's an X-ray image. What you're seeing light up here, all right, that is putting a tiny bit of contrast into the joint, and we can confirm that we are injecting cells into the joint. This triangular structure here, that is the labrum, and we've injected into labrum as well. So we're very precise and very accurate with where we're placing the needle and where we're injecting it. And my expectation is because of that, he'll get a better result than if we were doing this blindly. Showed these pictures before. The picture on the left, ultrasound guided patellar tendon injection. Picture on the right, X-ray guided ACL injection. It's another case study of a gentleman, 41-year-old man, avascular necrosis and wear and tear arthritis. Injected his own bone marrow stem cells into the joint as well as into the bone. And here's why. So, picture on the left is his pre-treatment MRI. All right, this is the ankle joint right here. There's some fluid. There's also some arthritic changes, wear and tear arthritis changes. But the other concerning thing is here in the bone of the talus, you see it lighting up. That is essentially early stage avascular necrosis. If we don't do anything about this, the bone will eventually die and it'll damage the cartilage over it. The cartilage gets blood supply nutrients from the bone, and so we need to treat that properly. This is his picture, MRI picture on the right 3 months later. No more fluid in the joint. That prior swelling in the bone itself is resolved as well. So his MRI images look great. In addition, he is symptomatically doing great. This is a gentleman who works as a chef, and he's on his feet for 13 to 14 hours at a time, and he's doing absolutely wonderful. Regenerative medicine treatments offer safe and effective solutions for your pain. Okay, let's just take a look at some of these questions. Okay, somebody asking about if they have one knee replaced, they're having pain in the other knee. They've also got some lumbar stenosis. Can we treat the knee arthritis and the lumbar stenosis? Absolutely. Both of those are very amenable to treatment. Of course, we need to actually look at your imaging, talk with you, figure those kind of details out, but definitely you have something that is very amenable to treatment. And realistically, the two most common things that we see are knee pain and lower back pain. So absolutely. Okay, someone else asking gel shots in the non-surgical repaired knee. Yeah, so if you've had the gel shots 2+ years ago, that's not a problem. The main issue is if you've had the gel shots or a steroid injection in the last month from treatment before your regenerative medicine treatment, we would want that to be out of your body. So we normally say give it a month to get out of your body. So your prior gel shots, that is not a problem at all. Okay, wonderful. Okay, so more common questions. Is this too good to be true? So, there's experience in the field that's going on for a while now. My own personal experiences since 2008, the Regenerative Network has data since 2005. Philip Hernigue, who's an orthopedic surgeon based in France, has data going back to the mid-1990s. So, I see colleagues who say that this is all very new. And it's newish, right? But it's not new. It's a rapidly developing field. Again, but there's so much experience behind this. There's right and wrong ways. You need to have your expectations grounded in reality and based on evidence-based medicine. I have colleagues who 10 years ago would say they don't think these treatments work. And that was based on really being completely unaware of any of the data or evidence. Now those same colleagues say They're not sure, maybe it'll help, but again, they're still unaware of the data. So sometimes if you're not paying attention, some things seem new, but in reality, there's people who've been working on it and utilizing it for decades. And it's not really new, it's just that someone who's not an expert in that field is just not aware of what else is going on in there. I mean, if you showed me what is new going on in the state of the art of ophthalmology, I'm sure I'd be flabbergasted just because I'm not an expert in that. It's the same thing with regenerative medicine. So how long do results last? You know, again, Regenix has data that goes back to 2005. That's 19 years now. Data from Philip Hernigue goes from the mid-90s. That's over 20 years. I still tell people, think conservatively. If you have a chronic condition, you've been dealing with it for decades, expect that you'll likely need a repeat treatment at some point. That might be you've had a bone marrow stem cell treatment for your knee, and we're talking 5 to 7 years later about repeating treatment. It could be you've had chronic back pain from degenerative disc disease. You'd get a platelet treatment, 1 or 2, and you're good for a couple of years, 3 years. And we need to top it off again, booster shot it again at some point a few years later. So think conservatively. And the nice thing is that what we know is that these treatments will slowly improve things. Steroid injection, you get a fast relief and then fast decline. These kind of treatments, slow improvement for several months. Some point you're a plateau. If you're at your goal, wonderful, nothing to do, just watch. If you're not at your goal, then a second treatment would make sense. If you're at your goal and you start to decline, in any of those cases, when you do repeat treatment, you're not retreating when you're back down to your baseline. You're now treating at a higher baseline level, and now you're going to get kind of a stair-step effect where now you're getting to a higher level after that as well. Best way to maintain your results after treatment, improve your biomechanics, do everything correctly that may have started this to begin with, utilize the right joint supplements for inflammation. Again, understand a repeat treatment tends to be additive in that stair-step manner, and try to maintain ideal body weight, which will help reduce stress on your lower back and legs. If you have some weight to lose, losing that will actually help your metabolic health and inflammation, which can help with pain. I'm such a strong believer in the connection between metabolic health and musculoskeletal health now that we actually have our own physician-assisted weight loss program that we're utilizing to help people so that they get an even better response for their inflammation, metabolic health, as well as their joints as well. Costs, understand that this is usually not routinely covered by insurance. There are, however, about 2,000 companies in the country right now that currently have Regenix procedures covered. If you're interested in learning more about that, please go to regenixcorporate.com. Essentially, these are companies that are larger, they're self-insured, and so they can control their own benefits plan and what's covered or not. If you're having to pay out of pocket, here's some kind of general cost estimates. Prolotherapy is about $750, platelet-rich plasma about $2,500, and stem cells about $7,000. Keys to determine value are, number one, is your physician in clinic a regen med expert? Don't get treated by someone who's not, and it doesn't make sense. Are you receiving a real stem cell treatment or something that's been mislabeled? Less of an issue these days, but in the past, amniotic umbilical cord cells were being mislabeled. And then understand that these are in-office procedures, so you should be able to avoid hospital and surgery center facility fees that can really add up. Talked about this before, about what makes a regenerative medicine expert. A lot of different things, but really it's all of this. That's what it takes to be an expert. It takes time, takes experience, but that's the kind of way you want to get treated. Just a little bit about how we do things here at Chicago Arthritis and Regenerative Medicine. Focus on non-surgical treatment for your arthritis, tendinitis, injuries, and back pain. An evaluation that starts by looking at inflammation, instability, asymmetry, and their muscular issues. If possible, correct or try to treat with low-risk interventions, exercise, and supplements. If that's not working, then progressively escalate treatment to regen med treatment, in which case we're using the best possible products that come from your own body. Plan that's very bespoke and tailored to you, not to somebody else. And injecting and delivering cells utilizing really the highest level of imaging guidance possible so that we give you the best chance of a good result. If interested in getting evaluated, for those of you on the Zoom call, you can see the list. You can contact us either via phone, email, You can even actually schedule directly into our scheduling system to get evaluated. If you forget all those routes, or if you're on social media right now watching this, just go to chicagoarthritis.com, and that can help you get evaluated as well. Wonderful. Well, we're getting toward the end of the hour. If anyone has any questions, please let me know. Yes, the first, great question. Can the first visit be telemed? Yes, absolutely. In that case, it helps if we've got imaging. The main thing that we want to know initially is what area is problematic, what have you tried treatment-wise, what's the actual problem, what's the severity of the problem, and then that's a good jumping off board to kind of decide, are you a proper candidate? Is there additional testing that we need to do? And then generally kind of figure out how to proceed from there. Wonderful. Well, thank you everyone for your time today. If we can be of additional assistance, either in helping with your medical care or with friend or families, please let us know. I think there might be one more question sneaking in. Maybe. But if we can be of additional assistance, please let us know. If you're connected to us via Zoom, you registered through the Zoom link, you'll get an invite to rewatch this when it's posted onto our YouTube channel, and you can share that with friends and family or colleagues if interested. If you're on any of our social sites, we'll probably try to post this or some clips from this as well, so you can rewatch that as well. And then again, of course, we're always available via the website at chicagoarthritis.com. Thank you everyone for your time today. Hope everyone stays healthy and live well. Bye-bye.